Okay, so it's noon. We'll get started. Good afternoon, everyone here in person. We have a nice crowd here, a large crowd here today. And those of you online, welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a brief reminder to please enter your questions in the chat at the end of the presentation, and please answer a survey that will be sent to you from Sylvia from Medicine Reception. Once you answer the survey, we will know that you were here today. And finally, our speaker today comes to us from the Division of Medical Oncology, and I would like to ask the Chief of the Division of Medical Oncology, Dr. Nathaniel Bouganim, to please present our speaker. Thank you.
Thank you, Nadia. So I'm very happy to present Dr. Ramy Saleh. Dr. Saleh, a lot of you know him already, but has been with us for now quite some few years. He graduated from internal medicine at McGill and did oncology at McGill, and then went to Princess Margaret to learn phase 1 and new drug development. He also did some epi at Harvard, and came back and had to fill big shoes in order to rebuild the clinical trial group for oncology, and now serve as the head of the oncology clinical trial group, and also founded and is the director of the phase 1 unit. So someone really at the cutting edge of clinical research, especially with new modalities, new treatments, first in human. And he'll be discussing with us something quite exciting in oncology.
Are you moving the mouse? Thanks, Nat. So, hi, everyone. Today, I was asked to talk about radioligand treatments, reason for which it's a new way of treating cancer. It's an exciting way, and there's really a lot to learn. Just like any oncologist, we start with our disclosures. It is not moving. Let me just see. Perfect. So this is a slide that I learned when I was a medical student. It is a very depressing slide, in my opinion. It's basically since the 1900s, we've been recycling chemotherapy over and over again until approximately 2005. So in 100 years, there was really not a lot of change in oncology. We're just creating more and more chemotherapy, more of the same, with not a lot of good outcomes. And only by the late 2000s, we started getting more into the immunotherapy world, and better technologies being created. So if you think about it, this is chemotherapy today. This is how an oncologist looks at it. It's an ancient history. Slowly, chemotherapy is being replaced. If you know about bladder cancer, for example, in bladder cancer, metastatic, we don't use any more chemotherapy. It's out of the way completely, and soon to be replaced in all of bladder cancer. So slowly, chemotherapy is becoming obsolete. And this is important. Why? If you look at the US data, looking at cancer in general, there is better 5-year survival rates. And that's not only because of better detection, but also because the treatments are getting better. So people are living longer. And the reason why they're living longer is because we're getting better treatments and better understanding of their disease. Is it you using the mouse or me? It is you. Okay. The thingy down here. No worries. So we go back to this. So this became this. So now we have really good treatments. However, they come with a higher price tag, more complicated maintenance. And sometimes we don't even understand how they work exactly at 100%. And this is the world that we live in oncology at the moment. So we have great new treatments that are very expensive, but we're still learning their side effects. We're learning how they work. In the oncology world, I would say 90% of the people doing research are focusing on what I'm listing over here. So we have monoclonal antibodies. We have things called bispecific or trispecific if you do hematology malignancies. Interleukins, we hear about things called oncolytic viruses or custom-made viruses for the cancer. Dr. Spicer is doing it in lung. I'm doing it in bladder. But also we have the CAR T cells that everybody gets involved in medicine if they have complications and require long admissions. But this is 90% of the wave. Everybody is focusing on getting new intravenous way of treating cancer. So what is RLT and why is it not part of this? It's actually the old becoming the new. It's not really a new treatment. It's actually a very old treatment. So if you like history like I do, Marie Curie was very well known and pioneered radioactive substances and their use in humans. So in the early 1900s, this is where she discovered that radiation or some kind of radiation can cure malignancies. And in 1937, there was a first approach for surgery and radiation. And the first time it was tested in thyroid cancer and prostate cancer was in the 1940s. So almost 80 years ago. In the 1940s, they tried multiple times to use radioactive substances to treat cancer, but we did not have the good technology at the time. So it was dropped when chemotherapy was created in 1949, because chemotherapy tended to be easier to be given and better understood. The problem also with giving radioactive substances is we did not have machines at the time to know what we're doing. So we created or discovered radioactive treatments in 1940, but the PET scan was discovered in 1970. So imaging was at least 3 decades late. And this is why it was dropped at the time. Moving to the 1970s, we started getting better understanding on the hormone effect, getting more treatments in place. And only in the 1980s, where we realized that there is some kind of radioactive treatment possible for prostate cancer with the bones. And in the 1980s, we realized also in rare tumors like neuroendocrine tumors. So not a lot of great stories. And then what I want you to focus on is in the 1990s, Europe started approving radiation therapy for prostate cancer. And immunotherapy was created around that time. So again, the radioligand treatments was put on the shelf because new, better, or easier treatments came about. And in 2005, this is when we discovered that radium is a good treatment to treat bone cancer or prostate cancer metastasizing to bone. Then 2011 or in the 2010s, we're really busy with immunotherapy and how we can recycle it to push it in. And then we discovered CAR T therapy. So we're all focusing on just one way of doing things. And only in 2020, we started realizing that no, if we focus on RLT with better understanding, better imaging, and better techniques, we might actually get good treatments for cancer patients. And this is the era right now that we are living in. So what is RLT? It's basically a radioactive material linked to a target. And what it does, it will go and detect the cancer, link to the cancer, and then emit a wave, which is exactly this. So the radioisotope is linked. You cannot do this in a normal lab. You really need it in what we call a cyclotron. It's a big machine where you produce radioactive substances. There's not 200 cyclotrons in the entire planet, just to give you an idea. And basically, you link it to a target, and the target goes and fishes for the cell with the target. Mostly it's cancer cells, links to the cancer, and then the radioligand will emit a wavelength, if you know your physics very well, and then it will destroy the cancer cell or whatever's around it. So better than chemotherapy that goes in and destroys everything in its way, or immunotherapy that wakes up the immune system to hopefully go and attack the cancer. So very specific. So moving along, basically we inject the dye. It's done in nuclear medicine. We put the patient in a room. We treat them. The whole process takes maximum an hour's time. And then you observe the patient to make sure that they're fine, and then they get discharged home. The problem with this is that it requires a lot of patient hygiene. To give you an idea, if a patient takes lutetium, for example, they cannot sit with their loved ones and sleep in the same bed and use the same utensils for the first 24 hours. They have to not share the same bathroom, different utensils for the first 24 to 36 hours, and then they can get closer after that. So if we're treating elderly patients who rely on their loved ones most of the time, they find this annoying in a way from a quality of life perspective. So what is PSMA? And this is where I say nuclear medicine joins the team in oncology, and now they play a pivotal role. So we all think of nuclear medicine as a service provider. We send them to do a bone scan, or we send them to do radioactive isotope uptake. But over here, they're playing now the role of treating patients and not only diagnosing. So radium was a drug discovered in around 2005, and we understood that we give radium, which is an alpha emitter, to prostate cancer patients with bone mets. They tend to live longer, and this is the, let me see if, nope, I wanted to put the mouse, but it doesn't. We can see over here, the hazard ratio is great. We see that the people with radium tended to live longer. It added a few months, but more importantly, it gave a better quality of life for patients with bone mets because bone mets cause a lot of pain. And this is what we've been using for a while. It's a bit annoying to use radium. Why? Because Canada does not produce radium. In order for us to get radium for our cancer patients, we have to order it from France. And France has to ship it at this very specific time point because it only lasts a few days. So basically, we see the patient and we order the radium for 3 weeks later for the patients to get it. So we have to make sure we don't do any mistakes, or else we order radioactive substances for nothing. And then after 3 weeks, it arrives, and we have literally a certain time point to inject the patient with the radium, and that's about it. So why we cannot produce radium? It's because the planet doesn't have that much, I would say, cyclotrons to produce and that much material to give. So there's only few centers around I'd say, the world where they can produce radium, and France is the one that we deal this the most. Not sure what's going on. Let's see. So PSMA stands for prostate-specific membrane antigen. Couldn't be easier. Basically, it's an antigen specifically to the prostate that is expressed in 100% almost of all prostate cancer cells. And basically, now we know that we can develop a radiotracer that can be linked to a target that goes to the PSMA and linked to it. So basically, we have a specific treatment very targeted to prostate cancer patients. If you remember high school and your chemistry, it's actually right here. Lutetium is right here on the periodic table, and we also have the actinium. And those are the two products that right now we're focused on a lot in oncology. They're different in terms of their physics. Why? Actinium is an alpha emitter. I did not know this until I read about it a couple of months ago. So I'm teaching people after what I read a few months ago. But an alpha emitter basically has a short wavelength. So it will not affect a lot the normal cells around it. And it's very specific. And this is actinium. And lutetium, which is approved right now, is a beta emitter. So also specific, but has a wider range. So it can affect the cells around it. And bone is known to have bone marrow. So if you have a beta emitter, there's a high chance of causing bone marrow issues, such as pancytopenias. This is a case report back in 2016. So believe it or not, actinium was created before lutetium, and I'll tell you why I'm saying this. They took patients, such as this patient, who failed 1, 2, 3, 4, 5, 6, 7, 8, 9 treatments in prostate cancer. And this was their PSA, 2,900, where normal you should be less than 3. If you have a PSA above 20, 99.9%, you have prostate cancer. And this is the scan that they had, full-blown metastasis everywhere. They took 3 treatments of actinium. And as you can see, the PSA went down to almost undetectable range, and the patient was doing well. However, the problem with actinium back in 2016 is we did not understand very well actinium. So despite having a great response to the cancer, the patients were doing detrimentally bad. And so actinium was dropped. And we said, we're not ready for actinium because we don't understand the technology. Let's go find something else. And that was lutetium. So then lutetium was same thing, very bad PET scan, very high PSA. You give treatments, better PET scan, less lesions, PSA drops, patient is better. But they realized that the patient's quality of life is better. So they dropped actinium and they focused more on lutetium, saying, okay, now we have a better drug, so let's focus on that one. And this is where they started realizing that back in 2018, that giving lutetium to prostate cancer patients who are advanced, they have a better control of disease. And this led to this trial, which in oncology, this is the hallmark trial, I think, and the gate opener to the floodgate right now of all the trials in radioactive substances, was called VISION. And VISION basically said, we will take any prostate cancer patients who's metastatic, who failed 2 or more lines of therapy. They really did not care how many lines of therapy they had. And that's how confident they were with their drug. They said whether you fail 1 or 2 chemotherapies, 1 or 2 hormonal, 1 or 2 injection, it doesn't matter. We're going to take them, and then we're going to give them lutetium every 6 weeks, and it's 6 treatments. So it's not an indefinite type of treatment. It's not a chemotherapy for a year or immunotherapy for 2 years. It's only 6 treatments and you're done. And basically what they found is that a lot of patients took multiple lines of therapy. So, but it was very well balanced between the placebo arm and the lutetium arm. And this was the primary endpoint that everybody was excited about. So as you can see, there was a statistically significant difference between lutetium and whatever was the standard of care choice of the prescriber. And those are actually very sick patients. If we see those patients in clinic, I would say 90% of the time we put those patients in palliative care and we tell them we don't have any more option. So actually giving them an extra line of therapy and buying them another 15 months, I would say, would be incredible for those patients with a better quality of life. What they found out is that irrespective if you have liver cancer or not, you're a good ECOG or not, you're young or not, or your race, it doesn't matter, the treatment will work. And that was the excitement behind it. Another thing is also the rPFS. So they realized that there's a big difference between PSMA and the standard of care. Moving along, we never saw complete responses in patients who are that far advanced in their disease. In the lutetium arm, there was 9% of patients with a complete response. As you can see, 41% had a partial response and 35% had a stable disease. So basically, we give treatment, you only have a 13% chance you will fail. And the rest, we can guarantee you some kind of a result for at least 6 months. And that was incredible in prostate cancer land when most patients were going to the palliative route. Not only that, we also saw that the PSA drops sharply. And this is interesting for us because this is one of the few cancers where we have a blood test that can help us know where we're going. So if we have somebody with, for example, bladder cancer, I cannot do a blood test to know if we're going the right way or the wrong way. In prostate cancer, if I have a PSA, the PSA will definitely tell me, am I giving the right treatment for the patient or not? And we see with lutetium, there's a sharp drop in the PSA, and we're still learning this. We're doing a real-world evidence right now in Quebec, which we are leading, to see if the delta PSA drop indicates a better prognosis or not. If there's a 2 or 3 logarithmic drop, does that mean better prognosis versus patients where the PSA trickles downwards slowly? And the quality of life is, in my opinion, the best graph. Patients feel incredible. So prostate cancer patients who are metastatic come in with a lot of bone pain and fatigue. And we realize that when you give them Pluvicto, which is the trade name, and they come in, they tell you that they're feeling amazing. They regain their quality of life. There's less bone pain, they're on less medications. And we did notice that in one of our clinical trials where a patient was on oxycodone and dropped the oxycodone completely after 1 cycle of treatment because they were getting overly treated with pain meds. And we realized that's because of the quality of life. They do feel better. That's rare in oncology to find a treatment after so many lines of therapy in a cancer patient to have a great survival, great quality of life, and a great control of disease. But it did open the door to a new kind of treatment that we're all not used to. And we're going to talk for 2 minutes about the politics behind where we are right now. So this exposed a big issue in our healthcare system, which is this. So Health Canada, when they received the application back in 2022, Health Canada said, I have no problem approving this drug. It makes sense. We saw the data published in the New England Journal of Medicine. So this is great. Let's approve it. But since 2022, PCODER and every single CADIF and every single, I would say, governmental agency to approve a drug financially refused to cover the medication, despite approving it since 2022. We've never seen this in oncology where it takes 3 years almost to negotiate. Which was very ironic, is that we got the final rejection back in November 2024, and the company was closing down its business, literally, and shipping their business back to Europe. And after a month, for no reason nobody understood, there was a reversal in the decision for approval. Now, what the problem that happened is whoever's first wins right now. And this is the world we're living in. So Ontario jumped on the boat and said, well, now that's approved, I will approve it financially. So on the 27th of December, Ontario approved using lutetium in their practice. Nova Scotia approved it on the 1st of February of this year, and Quebec, we are silent. Yesterday, there was a radio show host that went and called the government and said, where are we? Instead of saying we are going to approve it, they said we are still thinking about it. And that is a problem because the equity among patients in Canada right now, there's a big discrepancy. So what we don't want the Quebec patients to go to Ontario to get treated. And definitely the people in Ontario are going to say, well, I have a waiting list. You have to wait. Because there's a lot of patients waiting for treatment. But also you don't want patients like my patient yesterday who sold his car so they can get one treatment in private. Also does not make sense. To give you an idea how much the treatment costs, per injection, you can do it in one private clinic in Quebec. It costs $27,000 a shot. They give you a discount, so you go down to 23, which is I'm not sure if that's called a discount, but this is where we are. And this is exposing a big issue in our healthcare system where Health Canada is approving, but in order to get it into practice, it's very difficult. What I failed to mention, which is important, is that we just cannot prescribe lutetium. We have to screen patients first. So we cannot even screen patients and get ready for whenever the government agrees to approve. Why? Because also the government has to pay for the screening agent. So it's not easy, and we're really stuck in a very difficult situation where right now there's a lot of patients I call and I say, hopefully next week. And it's estimated that there's around 250 prostate cancer patients who are waiting just for the approval for them to jump on the boat and get that treatment. What we don't know also is, can all the sites receive those patients and treat those patients? We don't know. In Ontario, when they opened it up, it was a disaster. They could not pick up very well. In Quebec, I'm not sure if you know, but if we compare our province to any other province, the higher amount of PET scans and CT scans and MRIs and nuclear medicine doctors by far is in Quebec compared to anywhere else in Canada. And the only province that conducted all the trials for RLT in all of Canada is actually Quebec. We have, if you take all the last 10 trials of RLT, 95% of the patients were treated in this province. So it's a bit weird that we are the province who have the most experience and the biggest team, yet we are the ones who did not get approval, and we're just sitting looking at each other. That was my little governmental rant. Now you tell me, why is it important and do you think it will be used? Well, yes, irrespective of the kind of patient that you have, lutetium is here, 1, 2, 3, 4, 5, 6, 7, 8, 9. There's different indications for lutetium, and it's getting closer and closer. So now we're even trying to see if we can give it to patients with earlier stage of prostate cancer. So we cannot not approve it governmentally if it's going to be the standard of care even in earlier cancers. We just have no choice but to figure out a way to use it. So now with lutetium, is this the end of RLT? And this is where I say the MUHC leads the way. So like anything, once we have one discovery, we try to invest time to figure out, is this one-time shot or should we have different kinds of treatments that actually make sense? So I put for you this. This is the trial which I'm very proud of. The research team is here, which I owe a big thanks to. Because of the research team, we're able to secure a new clinical trial in prostate cancer, reusing actinium, the drug that I told you we tried and failed. But this time we learned from our mistakes. We knew that the issue was not the actinium, the issue was actually the vector. So if we fix the vector, human bodies can tolerate it better. And this is, our Minister of Health was very proud for once from our institution, saying that we have a trial when we had the first patient in the entire world who received actinium, who is, by the way, still alive. But it shows you that slowly but surely the MUHC is becoming the RLT center, whether in clinical trial or in practice. Right now, as Nathaniel mentioned, I have a bird's eye view on what's going on in clinical trials. So there is no RLT happening in Canada that the MUHC does not lead. And this is, because of the work of the people in the room. Now, what's the difference between actinium and lutetium? The reason why we're excited about actinium, it's more specific because it's an alpha blocker, so less emission to the healthy cells and very specific to the cancer cell. It has a half-life that is longer, so it can stay more in the body to give a better effect. And very humbly speaking, looking at the patients on trial with actinium, the responses that we're seeing are quite more dramatic than what we're seeing with Pluvicto. So at some point in the next 5 years, we're going to have another treatment that will need to be approved by our government in order to give to our patients. So what are the challenges and what is important for us as an institution? And why are those challenges important? I did not realize the challenges until we started opening trials. And I realized, we've never talked to some people. I don't know where nuclear medicine is. I'm not sure if you guys know where they are located in the building or who they are. And nuclear medicine people do not write notes. So that's also interesting. And we actually had to sit down in order to figure out on what's going on. So the first question is, clearly there's a need for nuclear medicine doctors. This is not a neuroendocrine tumor that we see 2 patients a year. This is prostate cancer, which is the largest, most diagnosed cancer in men. So the first question is, do we have a lot of nuclear medicine doctors? And the answer is no. Do they train a lot of nuclear medicine doctors a year? The answer is also no. Are nuclear medicine doctors excited on participating in clinical trials? Most of them no, because they've never been part of clinical trials. So we cannot ask somebody who's been in practice 20 years to start doing their GCP and their training to start participating, because this is something that they've never done. And then who makes the decision on what to order? So is it the oncologist that decides that the patient needs Pluvicto, or is it the nuclear medicine doctor that decides that the patient needs Pluvicto, or is it the radiation oncologist that decides that I think this patient needs treatment or not? And I can tell you in all of Quebec, nobody figured that answer out despite so many meetings, and everybody's trying to wing it in the way where they feel the most collegial. And then the question is, do our patients need screening with PET scans that are FDG PET, or do our patients need screening with PSMA PET? I'll tell you why. Or do we need both tests? Well, if we need both tests, then we need more machines, or we need more time on the machines. And as we all know, finding a PET scan for our patients is like a miracle. So how are we supposed to put 200 patients 2 times, so 400 PET scan appointments for our patients to put them on trial? And that we still did not figure out in the province with the highest amount of PET scans. And that's a discussion that we have to see with nuclear medicine. Are you able to sustain all of that load, or should we prioritize the sickest patients and put the less sick patients on the back burner? But then is that fair? And who is making that decision on who is sick and who is not sick, and who deserves or merits the treatment and who does not merit the treatment? But those are the discussions that we're having. And also the burden on our healthcare system. So in order for us to absorb, I think, the first wave and going forward, we have to work as a unit, as a whole province, which means all nuclear medicine doctors should feel comfortable with the treatment. I'll give you an example. There is one big center in this province that is a few hours away from here. They decided they do not want to do Pluvicto. They're not comfortable. But that means that whole region has to be plugged into a place. So who is that place? Is it the MUHC? Is it the SHUM? Is it, for example, St. Mary's because they have less load on nuclear medicine? Should it be them? Are they able to acquire those patients? If something happens, does the patient go back to the primary hospital, or they stay at St. Mary's? And the problem is that we have to work as one unit. If we start fragmenting, then the care is going to be a disaster for those patients. And that is something that we still did not figure out. Even the nuclear medicine doctors still did not figure out on how they should ally together. Right now, the rumor is that Trois-Rivières has a huge army of nuclear medicine techs, so they can absorb a lot of patients. That's great. Sherbrooke City is, I'm not sure if you know, the people who invented almost PET scans and nuclear agents. So they have an army of people. They have 5 research PET scans. We don't even have 1. They have 5. So they can maybe absorb the load, but it doesn't make sense for a patient to travel 5 hours to go to Sherbrooke. So we still did not figure that out, which is good and bad that the government didn't approve this yet, hopefully for us to figure out how we're going to do this. But this is the world that we're living in. And who orders the test and who decides to give it? If I order the tests, can the nuclear medicine doctor cancel the test because they believe that the patient is not worthy? It's like me telling, I'm looking at Dr. Pickering, it's like me telling Dr. Pickering, she orders a CT chest on a patient, and then the radiologist calls her and tells her, you did not convince me, so I'm not going to do it. We've never had that issue before. We order CT scans and they go and they do it. But here it's going to be different. I will order the Pluvicto, and a lot of nuclear medicine doctors will say, I don't think this is a good patient. And we have to figure out on who at the end of the day should make that decision. It won't make sense to discuss all the patients in tumor board, because that's hundreds of patients. We have to figure out some kind of an algorithm, and this is something we're trying to develop in Quebec. Moving along as why we will butt heads with the nuclear medicine doctors is because at the same time Vision, which is on your right side, was approved, the Australians, who are very well known in this, but staunch believers of over-imaging people, did the trial mostly on the left side. And as you can see, the percentage of excluding patients is more than double. And the reason for that, they decided that in order to screen patients, we will not screen them only with a PSMA PET, a PET scan with a PSMA agent, but we have to do both, the FDG and the PSMA. And why is that? Because on the FDG PET scan, you can see here there's a lesion. And you can see on the PET scan, there's a high uptake on the FDG PET. But if you look at the PSMA PET, the CT scout will show the lesion, but on the PSMA PET, the lesion does not exist. And that's called disconcordant. That means if I give this patient a PSMA targeted treatment, that lesion will not be treated. So that's called the disconcordance. And now there is this huge war among nuclear medicine doctors. Should we do both scans or should we do one? And which patients are worthy of 2 and which patients are worthy of 1? Now, why is that important? So also here you can see on the PSMA PET, you can see there's a missing lesion, right? But the PSMA PET did highlight other lesions, but look at the FDG PET. It highlighted one and not the other. So this is also called the discordant lesion. And we do see that in practice. Not common, but it is common in a way of 10 to 20%. So why give this person a very expensive treatment knowing that it will not go to the cancer? So for example, this gentleman, on the FDG PET, we see that the PET scan was almost clean. On the PSMA PET, we see all the target lesions were there. So this, despite the discordance, this patient makes sense to give them a PSMA treatment because on the PSMA scan, they're all there. So definitely we should give a PSMA targeted treatment. Versus this one, this is the PSMA PET. It shows nothing, but on the FDG PET, we see different lesions. So it doesn't make sense. We should not give this patient a treatment. So sometimes we can make a case. So I can be the devil's advocate and play on both sides of the fence. I can say every single patient will need both scans. Or I can say, well, do we really need both scans? How about we treat and see if the PSA drops were good, if not, not. But we don't know what's the healthcare burden cost of doing the shotgun approach and giving everybody treatment versus the other way. This is, for example, the FDG PET, the PSMA PET of a patient that lights up a lot. And then, as you see with treatment, the lesions are disappearing and the PSA drops. And that's why we like that kind of treatment, because we can see the PSA response in the patient, so we know. But if you look, for example, this patient tended to drop, and then after a few cycles, his lesions started going up and the PSA went up. So this patient maybe should have not gotten the treatment because they could not even benefit. They were failing the treatment as they were taking it. But we still don't know who is worthy and who is not worthy. What about the side effects? So one question I ask is, if the nuclear medicine is the person giving the actual treatment in the nuclear medicine floor, is the nuclear medicine doctor responsible for managing the adverse events of that patient? Because if I give chemotherapy, I am the person who is legally liable on managing the chemotherapy side effects because I am the prescriber. But I am not the prescriber of the treatment. It's the nuclear medicine who's going to go to their nuclear medicine fridge, get that treatment, and give it to the patient. Which means, will the nuclear medicine write a note? I gave this patient. And that was a discussion. And then at the MUHC, we had the agreement. Don't write a note, but write it in imaging as a treatment. So if you look at the imaging on OASIS, when it says Pluvicto, it says, I gave this patient this, milli-equivalent of that drug and tolerated it well. But we needed them to do this, whereas there is no documentation that the patient actually took the treatment. But then the question is, do they have MUHC privileges to admit? Dr. Rogers, right, the idea of putting them we should put them on the DPS criteria. Maybe we should find them some beds, but they can't because they don't have a service. They cannot come down. They cannot treat. So then the deal that we did with nuclear medicine is, okay, you give the treatment, I handle the side effects of the treatment. But it was a discussion because also the ER, when the patient comes to the ER does not know, do I call the oncologist? I'm only writing a note saying patient will be treated, but I don't know the date of the treatment, neither do I know the location of the treatment. So the patient goes to the ER doctor will only have the small note of the nuclear medicine, and then confusion will start on who does the ER person call. And this is something that, believe it or not, took 4 months for us to figure out. So what is the ER algorithm and the rules? Should they go to medicine? Should they go, because nuclear medicine is under imaging, I'm not sure who admits, or should it get admitted under oncology? This is a question we're going to have to ask because now we only have less than 20 patients or 25 patients on those treatments. But when we have 100 to 150, the incidence of going to ER is going to increase. Then we have to figure out a special algorithm for those patients, which we don't have right now. And then what is the role of medical oncology? Is the medical oncology just to look at the patient and say, yes, there's a side effect, I can see it, but now I have to call the nuclear medicine so he can help me? Or do I call other people in the internal medicine umbrella so they can help me? So if they come with pancytopenia, do I call the hematologist and I tell the hematologist, what should I do? And the hematologist will tell me, well, is he emitting still? I cannot touch him because he's still emitting certain wavelength of radioactive material, so maybe we should isolate. So we're still not there yet, but in my opinion, medical oncology should take care of the patients, given that they're very advanced. We just have to figure out how we're going to talk to the other people managing the patient with us. The problem with actinium is, number one, it is definitely the future, and it's definitely better than lutetium. We just unfortunately have to go through the process of phase 1 to phase 3 clinical trials. The disaster of actinium is that it has xerostomia, almost at 100%, like a guaranteed. You give them a treatment, 2 days later, they tell you, I have dry mouth. And I cannot eat very well, I cannot produce my saliva, I'm drinking more water, or my eyes are dry. The challenge is who do we consult for those patients? So when we had the first patient on actinium, had a little bit of xerostomia, so we did not worry. The second patient who had it, we did not really know what to do in terms of management, and it's a phase 1, so the company also doesn't know. They just told us, do whatever you see fit. So our great coordinators with the fellows and the nurse went to ENT and told the ENT people, what do you do for people that you remove the salivary gland? Give us your protocols, we're going to use it. Then we went to Dr. Buganim and radiation oncology and told them, the people who you radiate the area that have head and neck cancers, what do you give them? And we spoke to GIM also, to the endocrinologists as well, and saying like, what would be things that can excrete saliva, or what are the procedures? And I can tell you that all current standard of care treatments for xerostomia on the planet fail to address xerostomia of actinium. At the SHUM, they are trying with a company to auto-inject medications into the salivary gland of patients, and that did not work. But there's billions of dollars being invested in figuring it out, because this will be the rate-limiting step of our patients. But that also means that if a patient comes to the ER, we're going to have to consult people for something very weird. I'm pretty sure right now if I call ENT and I tell them, hi, I have xerostomia in the ER, they're going to hang up and not take it too seriously. But that is a rate-limiting step for the patients to get treatment. And sometimes it stays for quite a long time. And what about the kidneys? So one question that I keep asking the companies with all their new designs is, how much nuclear agents can a human body actually tolerate? Like at some point, we're going to turn off the light and we're going to emit and we're going to glow in the dark, seriously, because right now we give them radium and then we give them Pluvicto and then we're going to give them actinium. But how much does the kidney actually tolerate? We don't know. We started to see kidney failures in some of the patients with the newer drugs. So are we really pushing the limits of a human body to the limit? I'm not sure. But one thing that definitely is going to happen is we're going to consult nephrology more and GIM more to help us with kidney failure. But that will be a weird kidney failure consult. Hi, kidney failure because of radioactive substance. What should I do? And how do we manage it? And what are the medications that we can give to improve it? If I was a cardiologist, there's been also cases of pseudoamyloidosis in the heart and cardiomyopathies after RLT. So why is that? Why is a nuclear agent going to the heart? What is expressed in the heart that is causing heart failure for those patients? And how do we test it? I'm not sure if Dr. Janetti knows, but I don't know, like, can I actually biopsy a heart while a patient is radioactive? And how do we handle that sample? Or is the radioactive material too low that a human can actually take the sample and read it? And what would be the management of that? So those are all big question marks that nobody actually has the answer to, but we're living them all the time. So all of this is in prostate, which is great. So now we know prostate cancer, we found a new type of treatment, so let's go. Question is, are there any other cancers that could benefit? The answer is usually yes, right? So pharma got too excited and they said, well, can I do RLT and something else? So while 90% of the people are focused on immunotherapies and antibodies and CAR T cells, there are people who are looking at new targets. One of them, which is of a very particular interest to the head of nuclear medicine here, Dr. Abbaspour, is FAP. We realize that FAP is a very highly expressed target in cancer cells and less in normal cells. We could not create a medication against FAP. So I cannot create a pill, and I cannot create some kind of an immunotherapy or intravenous treatment for that because it's quite complex to do. Then the question was, if it's too complex on both sides, can I create a vector with radioactive substances to put it and see if I can go to the cancer cell? And the answer is yes. So Novartis actually is almost becoming the biggest pharma company in RLT treatment. Novartis is looking at, could we find a treatment against FAP, which is fibroblast activating protein? And I think Wayne here will tell us, everybody knows I call this trial the top priority trial. This trial will hopefully open this month. And if it does, we'll be the only site outside the United States who will be giving radioactive treatment to pancreatic cancer, breast cancer, and lung cancer. So also either a very aggressive disease like pancreatic cancer or very common cancers like lung and breast. And this is why getting exposed to RLT in meetings such as this will be important because we'll see this more and more in our clinics. So this is a phase 2 trial, which means the phase 1 was already done and we already saw the signal. This is a phase 2 where we'll try it in breast cancer patients and lung cancer patients to see if we can control the disease with or without chemotherapy combined. And hopefully we'll open it up and you're going to hear a lot about it. Another one we're trying to open up is also in hepatocellular carcinoma. So now RLT people are trying to figure out which targets exist in cancer cells and not in normal cells and develop some radioactive substance against it. And this is another trial we're trying to open up with Bayer. So what does the future hold? And what I called it is RLT is a renewed way to treat cancer. So if I was Marie Curie and I was in this room, I'll be very happy that what she discovered it took 125 years to figure out how to use. But at least what was discovered by her, now we're able to take it and treat malignancies. But there is a lot of caveats, and this is my last slide, but I want to spend a bit of time on it, and that would be the message. So number one, this is definitely only the tip of the iceberg. So in phase 1 trials, we had no RLT trials in phase 1 until 5 years ago. And 5 years ago, we saw one. And 2 years ago, we saw only one, and that was the actinium that we opened. And right now in our pipeline, we see 4. And in phase 2, phase 3, there's at least 15 of those trials. So the quantity of trials is not increasing by 1 or 2 a year. It's logarithmically increasing by a factor of 2 or 3, which means that we have to be ready either to do those trials or use them in our clinic. The best part of using them in our trials, it gives us an advantage because we will train ourselves and figure out our operational system before we put them into practice. So now, for example, it's very easy for me to know who's a nuclear medicine doctor, who are the technicians, how do they work. I know the hours that they can accommodate the patients. I know exactly which days of the week they like to give the treatment. I know which are the doctors that can read those scans because not everybody can. But that's the beauty of doing clinical trials. It gives an advantage to the patient and also an advantage for us, like a lead time bias almost. It gives us 2 to 3 years to figure out our stuff before we go in. But it's definitely the tip of the iceberg. Now we're seeing more and more RLT in different types of cancer, which means that one of them has to work for sure, if not more. Trials are expanding. So the trial that I showed you, which was for breast and pancreatic, was only in breast cancer at the beginning. And then they realized when the phase 1 trial ended that, no, there's a signal in lung and there's a signal in pancreatic. So we're seeing more and more amendments coming into the same trial to try to expand the trial to different disease sites. And that is exciting because those patients, technically speaking, the ones that I presented the trial, are patients who failed all standard of care, and their only option is either some kind of a chemotherapy that has a, 15-20% chance of working, or palliative care. So to tell them, I can give you a drug where I can screen you for it to make sure that your cancer cells have it, and then treat you with a specific treatment, is a game changer for those patients. Limitations. There's no limitations because pharma has billions of dollars to produce, to give, to do trials. But their limitation is how much RLT can we produce. I actually did not know this, and I did not know that cyclotrons are hard to build, and they cost a lot of money. And to build one, it takes around 3 years to build, and you have to get Nuclear Canada to come investigate, and there's a whole process. But when we opened one of our trials with lutetium, every couple of months, they tell us, please delay your patients. Please delay your patient. I'm like, why are we delaying the patient? They're like, well, we're unable to produce. And we looked at the trial, and in the entire world, there was only 25 patients on trial. We said, there's only 25 patients. How hard is it to produce 25, units to give to the patients? And they said, it's actually very hard. And then we said, okay, well, how many centers in the world are producing lutetium? And turned out there's only 2 centers, one in Europe and one in the US. And the problem was the US plant had some issues. So when that plant closed, the other plant could not overproduce because this is not something that you can expand. You cannot go from 5 a day to 500 a day in a week. That takes 5-6 years in production. So they said, we can't. The same thing is happening with actinium. So in actinium, instead of we screen the patient and we say, we are treating you, let's say 5 of April, the company will say, thank you for screening the patient, putting the patient on trial. I can only treat him on 8th of April because this is the only day that I can produce and ship it fast enough for you to give. And this is where we're seeing now pharma trying to see who is producing those radioactive substances and either purchase them or do business with them. But The only limitation would be how much quantity can we have. The problem is when those are going to be approved and everybody can use them, do we have enough also for our patients to give clinically? And that's what we don't know at the moment. It's a definitely more precise way to treat cancer. Humbly speaking, immunotherapy does not work in prostate cancer, and that was a big disappointment. There was 5 clinical trials with immunotherapy. I know we're all exposed to immunotherapy in one way or another. We now all agree that chemotherapy is something of the past, but immunotherapy is not the best thing. I think the golden era of immunotherapy is 7 years behind us. Now we're living in the antibody drug conjugate and in the golden era of RLT, but it's offering a more precise way of treating without a lot of side effects. There's only 2 side effects with this. Myelosuppression and xerostomia. We do not see any other side effect like nausea and vomiting and hair loss and severe proteinuria or anything in the GI system. So the quantity of side effects is less, which is good for our patients. It definitely requires more manpower than what we have. So if I was a hospital, I would invest in nuclear medicine. My golden stick is Princess Margaret. So if we look at the news, Princess Margaret just invested tens of millions in only one department in the last 5 months, and that department was nuclear medicine. And the reason for that is they see that there's going to be a lot of pressure, so they need to attract the nuclear medicine doctors. And also, it doesn't make sense that nuclear medicine has 1 PEM a year, while we know there's going to be a lot of patients that are going to go to nuclear medicine. So they also have to figure out how do we attract and train more people to be able to treat those patients. But also, it's not about the nuclear medicine doctors, it's also about the technicians. So they cannot do their work without the technicians. So also we need to invest into the technicians in order to absorb. I don't think machines is the issue. It's more the manpower. And finally, how will we treat all those new side effects? So most of the side effects right now, this is recorded, but I don't think it's going to look well, but we wing it in phase 1. In phase 1, there's really no guidelines of how to treat. We just ask our colleagues, try to figure out collectively among us what is an agreeable side effect management system. But to be honest, if the patient has proteinuria or heart failure or pancytopenia or dry mouth or dry eyes, there's really no algorithm or up-to-date or anything online that tells us you should give this or that. Plus, what I tried to show you before is that if they have a dry mouth or dry eyes, there's nothing on the market that actually can help the patient. So I think we are creating medications faster than we are creating medications to tamper their side effects, or we don't have anything right now for the new side effects that we've never encountered. So the question is, how do we treat those side effects, and then how far can we push the human body? And that would be the question, because there are clinical trials right now that are looking at giving actinium to patients post-Pluvicto. And their interest is, 1, can we overcome the quote-unquote resistance of RLT, but 2, can the human body tolerate it? Those patients are not in prostate cancer. Most patients are 70-year-old patients. So their creatinine clearance is definitely not above 60. They're in the 50s range most of the time. So can somebody with a grade 3A chronic kidney disease handle a huge quantity of radioactive substance and then eliminate it comfortably and be able to receive another treatment? And this is why, if you can see, the treatments are once every 6 weeks, because they're spacing it so they can eliminate. Another question that I was asking the companies is, how radioactive are those things? Because we had that debate in this hospital with the lab techs. So when the lab people knew that they will receive samples from the SIM with radioactive substances, they did not want to analyze the samples. Because am I putting a radioactive tube for a CBC with regular patients, and then my machine will be tainted with radioactive substances? So we had to do a whole investigation on how much quantity of radioactivity was in the blood tube, and should we put the blood tube in the, what do you call it, in the thing that transports the pneumatic tube, thank you, or not? Should we put it in a different bag? Should we label it differently? Should we handle it with different types of gloves? So that put a lot of pressure on every single person in this hospital in trying to understand, how do we do it? If the patient is sick and comes in within the first 24 hours, how do we label this? And the patient is not supposed to be close to their loved ones by a meter. So let's say I give this treatment and the patient goes home, and after 4 hours, I don't know, starts bleeding, and they come to the ER. How do we tell the ER that this person needs to be isolated because they are emitting, radioactive substances to a point where no patient can sit? And we all know in the ER right now, they're all sitting on a chair with people around them. And that will be a challenge. We have to figure out a way to tag, quote unquote, those patients and isolate them from the rest if that happens. So far it did not happen, but it's something we have to think about. One stupid thing that I'm thinking of, which I always ask, is if those elderly people are in a CHSLD and they have a water reservoir and there's 5-6 people getting Pluvicto in one big building of 500 people, and they all flush the toilet and pee, is this radioactive substance all hubbing in one area? And what could happen? And that is a question we're asking because the quantity of patients is going to go up. So we still don't know, but I think time will tell over the next few months. And that's it. Thank you.
Thank you for your terrific presentation. Thanks for bringing it home to the MUHC. And congratulations on what you've done.
Thank you.
With your clinical trials and advancements for your patients and for the MUHC, putting us on the map. Any questions in the room, or there's a few questions? Oh boy, there's quite a few questions in the chat there. Okay, so
you want me to go through them?
Yeah.
Yeah. So to answer Dr. Rosenblatt, yes. So yesterday I was actually also on the radio, and we tried contacting the government. We also sent a letter to the government, and actually the government is not actually answering us. So we don't know if this is going to take 1 week or not. As for the committee that meets 3 times a year, no, it already passed that committee. The only step is getting the file to the minister's desk for the minister to sign it. I think this is where it is stuck at the moment.
Repeat the question.
Sure. So one question is, in what such an expensive medication is better than actual treatments that are currently available? And it's an indolent cancer to the point that there's no formal screening guideline in first line. So the patients that we're giving them this treatment failed all standard of care treatment. So they don't have actual treatments. This is a new line of treatment. And so this is why there's really nothing to be compared. For Dr. Rosenblatt's basic biology question, no, I do not know why those proteins and folate transport metabolism are involved with some specific cancers. So I don't think there's anybody actually looking at that at the moment.
There's a question, sorry, I'm just going to interrupt. There's a question by Dr. Thurlow in the room, if you want to take that one.
Very great. Bonds for different metastatic sites that were
So that's a good question. The higher the SUV uptake, the better response, not the site. It's more the uptake. So if you have an uptake of 15 or more, there's going to be a better response in that site versus an SUV uptake of 5. It's not the location that matters. It's more the uptake of the tracer that matters. Sorry? No, that was dropped in the 90s and the early 2000s because of severe toxicity.
Thank you.
There's a question here about the radiation that's used in thyroid cancer, the radioactive iodine. What happens to these patients when they go to the emerge? Is it this sort of a similar sort of situation?
No, because those patients are admitted and sealed in a room for 4 days. We don't give them and tell them to go out. They're actually discharged only when they pass a certain radioactive level. Prostate cancer patients are treated as an outpatient, so they don't get admitted. And by the way, I think we have only one room in the hospital that is lead closed, I think, and that's on C8, if I'm not, or C9, C8.
So, sorry, can I just ask you a question about that? So why is there a difference between your experimental protocols with these new radioactive emitters versus the I-131?
The I-131 is a much higher dose, 1 shot, versus those are lower doses, 6 shots. It's the first initial quantity. So the person that's taking it, they're actually severely emitting. I think they have to be 5-6 meters away from the closest person. And that's why even the room is too thick, because it can bypass a regular...
So the Health Canada approval process, presumably for these drugs and these trials, also takes into account all of the things
Yes.
that you're mentioning. About,
Correct.
Exposure of family members, exposure of healthcare workers, exposure of lab.
Well, the Health Canada approval does say that you have to stay 1 meter away from family members in the first 24 hours. So it dictates it. Our question is, in the first 24 hours, if the patient comes to an ER or gets, exposed to other people, how do you stay and how do you identify those people to stay away? The risk is negligible, but it's there, or else it would not have been mentioned, right?
So there's a comment here about cost from Stephen Grover. It's a bit of a long question, but he was suggesting that it's 50,000 per quality adjusted life year, so per quality. Has the price dropped since that first analysis from 2022 was presented?
Yeah, so we do know that the company lowered its price significantly. We don't know what significantly means, but speaking to some people, I know it's 50 to 60% less than what they actually charge in private. But that's why I think the government finally agreed. Radium costs $2,000 a shot, just to give you an idea, versus Pluvicto, they started at $27,000. So I think they had to go down for that. And definitely that impacted the approval.
There's a question here about the radio label aptamer oligonucleotides being used for cancer. Is that being used?
No, not to my knowledge.
Okay. You think it would be cost effective or good investment for private enterprise to build a cyclotron to generate these radioactive compounds? Is there a good future for that?
That's not so. Being not political, this hospital is a PPP. Maybe we can get that dead space next to the RI and build a cyclotron there with the private and cover all our costs. I think that would be
You
great.
need a whole building, including an ER and
Yes, probably. But we do have a cyclotron at the MNI, just FYI. There is one, an older one that's located at the MNI. So some of the centers do have, but it's smaller scale ones. The largest one is in Sherbrooke City, and they have two. One which is from the 70s and one developed in 2021, I think.
Any more questions in the room? Because there's quite a few questions in the chat, Mark.
Yeah, I wonder if you could talk about the xerostomia and its impact on quality of life. You sort of alluded to it being potentially a short-term thing. The overall quality of life in these studies, from that sort of quick flash you put out, was better. I guess that's...
So lutetium doesn't cause it.
Yeah.
Lutetium doesn't cause it. It's more the newer ones, actinium, but those trials are still ongoing. But from the experience that we have, patient one still has xerostomia till today. The problem with xerostomia is that the grading is very subjective. So I'm not being ironic, but you should ask the patient, can you eat a steak? If the patient tells you I can eat a steak, it's never a grade 2. So there's different ways, but to do a spit test, we ran into trouble because our spit test was being done in a tube versus the spit test of Toronto was being done in a Petri dish. So the saliva was not the same. So it's a very subjective grading system. But almost all patients will have some kind of a dry mouth. And they will tell you there's a big difference before they started treatment and after they started treatment.
But enough to overwhelm the beneficial effects?
There was one patient who actually asked to leave the trial because he could not continue eating properly and everything was soft diet.
Juan is saying here 90% of the thyroid cancers are treated from home. Juan, do you want to just say, let us know, Juan Rivera, maybe just put a comment in the chat how that works in terms of if they come back and how we can use that experience to
we tried
to
that.
advance us. Yeah.
We actually tried that. That's why I said endocrinology. We actually asked them what they do for thyroid, and that also did not work. We now actually prophylactically treat everybody as if they're having salivary gland radiation by giving them everything from pills to gels to popsicles also ahead of time, but nothing is actually stopping the xerostomia at the moment. But thank you for that.
Dr. Skamini is asking about upcoming radioligand trials allow for external beam radiation therapy washout, or is there a washout required? What do you do with that?
No radiation is allowed during treatment. And I think they're concerned about radioactivity plus radiation to the same target. So the washout is 6 weeks in one of the trials, 4 weeks in another.
There's a question about prolonging life. So these treatments do prolong life in prostate cancer?
Yep. So there was at least 3 to 6 month increase in OS. On a median, but I can tell you we have a trial in hormone sensitive with Pluvicto. We put 11 patients, which was the highest in Canada. 2 out of those patients are cured from metastatic prostate cancer. We cannot find any evidence of disease after treatment. So in some people, the survival is high, and some of them, we did notice a high cure rate, and I don't know what to do with those patients. So one of them actually decided to stop all treatments.
just to, a lot of things that we do sort of at the MUHCs, we grow organically and we just keep adding and adding and adding. And, already it's hard to access nuclear medicine tests. I can tell you in cardiology, I saw a patient this morning who's been waiting for a dip maybe for 6 months. It's not unusual. So kind of, do you get the sense that the whole sort of, you can look at this as a big picture, or is it going to kind of grow organically like everything else and just kind of squish all our resources? What's your sense of what's going to happen at the MUHC?
The thing is, the incidence of patients who need DIP maybe is kind of stable across time. It's not varying, right? Versus if we get oncology approvals, it's going to logarithmically increase. So the organic way of doing things will not work. And this is what I spoke about with Dr. Pelaj and with Dr. Abaspour. Is I really hope that you're training people who will come back and will be interested in research and doing this type of thing, or else we won't survive. I know that the SHIM is hiring more and more nuclear med techs, but the doctor's pool does not exist. Like literally, it does not exist. It's the same doctors over and over. They barely hire 1 or 2 new staff a year in all of the province. And if you look at their PEMs, there's 0 PEMs for like 3-4 years. So we cannot do this organic growth of let's wait for somebody to retire to hire somebody who has an interest. It definitely has to expand the pool quickly.
So a lot of lobbying needs to be done.
I think so.
Yeah. Okay.
I'm not looking there. I'm looking there.
Maybe just a comment, we're trying to cut out 1.5 billion out of our healthcare system. And, that's including closing like up to 175 long-term care beds in our WIS. And we have, 110 NSA patients in the hospital. There are many sort of very low cost interventions that are impacting our ability to deliver care to very common illnesses. It does become an ethical, societal question about how we deploy our resources.
To grow on that, just as a final point from my end, I think as a midterm solution, the more patients you put on trial, the less burden on the healthcare system from a financial point of view. And trials do bring profits to invest it into the center. So if we're able to get more RLT trials, we don't need to treat them clinically. So you save on that cost, but then the profit that you're getting can be invested in nuclear medicine so we can expand, at least at the beginning. Let's not forget, if we are becoming the epicenter of RLT in Canada, then we can definitely even do partnerships with pharma to help us support that. I don't think that's a crazy thought. It's a very easily achievable one, but as you mentioned, definitely needs some unique lobbying to get that through.
Thank you very much. Congratulations for all the work you're doing and for your perseverance. It's so important. Thank you. Thanks everyone for joining us. I wish everyone a great afternoon.